The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, and welcome to today's webinar on the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Mike Soucy, and I serve as the Associate Director for Science in the Division of Blood Disorders at CDC. I'm pleased to be with you and will be serving as today's moderator. Our topic today is on evidence-based guideline on hemophilia care, being presented by a distinguished panel of experts in blood disorders. Before I introduce our panel, I'd like to go over a few points and helpful hints. Upon joining the webinar, you'll see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone number and access number and audio pin. All audio will be muted, and to submit a written question, please use the questions area of your toolbar. The presenters will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. We'll begin today's webinar first with an audience poll. We're interested in knowing more about you. Please select from the following options: inside the U.S. or outside the U.S. Okay. Looks like we have a few outside the U.S. Next poll. Okay, it looks like about half provide hemophilia care. Okay, and one more question. Okay, and it looks like a little more than half are staff at the U.S. Hemophilia Treatment Center Network. So thank you for providing that information. So now it's my pleasure to introduce our distinguished panel. Our first presenter, Mark Skinner, brings a strong background in public policy and advocacy. He has chaired or sat on numerous committees to address the safety and supply of blood products. He was chair of the NHF Advocacy Committee that was responsible for achieving compensation for people with hemophilia infected with HIV in the United States. Mark is also president and CEO of the Institute for Policy Advancement Limited, a nonprofit organization assisting charitable organizations develop an effective, sustainable public policy program. Our second presenter will be Dr. Menaka Pai. Dr. Pai holds a faculty appointment in the Department of Medicine, Division of Hematology and Thromboembolism at McMaster University in Ontario, Canada. Her clinical interests include both hemostasis and thrombosis, and her research focuses on the development of standardized clinical assessment tools for mild bleeding disorders and on strategies to encourage appropriate venous thromboembolism prophylaxis. Our final presenter is Dr. Stephen Pipe, who is Director of the Division of Pediatric Hematology and Oncology at the University of Michigan. In this role, he directs the Hemophilia and Coagulation Disorders Program and the Special Coagulation Laboratory. Dr. Pipe chairs the Medical and Scientific Advisory Council for the National Hemophilia Foundation. So with that, let's begin with our first presenter, Mark Skinner, who will provide us with background on the new NHF McMaster Guideline on Hemophilia Care. Mark, let's begin.
Hello. It's a pleasure for us to report to you today on the findings and conclusions of the National Hemophilia Foundation and McMaster University Guideline on Care Models for Hemophilia. As part of the NHF and its Medical and Scientific Advisory Council's mission to find better treatments and cures for bleeding disorders, in 2012 the NHF convened the Hemophilia Strategic Summit. The goal of the summit was to examine how the changing healthcare environment could affect care and treatment for those living with hemophilia. One of the core findings identified was an urgent need to strengthen the evidence base for hemophilia care. To support NHF in this task, NHF sought the assistance of a globally recognized organization with expertise and a strong track record in generating evidence-based medicine recommendations. Our search led us to McMaster University, one of the top organizations in the field. We are very pleased and grateful that McMaster agreed to join with us as we undertook the difficult task to develop a guideline for a rare disease where high-level evidence is often lacking. Moreover, this is one of the first guideline efforts launched under the new national standard for guideline development. And perhaps also notable, I believe it may have been one of the first where McMaster partnered with a patient-led organization. Next slide, please. I think we're ahead on the slide. Following a search and a review of existing evidence-based guidelines, and there are actually very few in the literature, and a review of extensive list of MASAC practice recommendations, the Guideline Scoping Committee recommended that the most urgent and appropriate first step for NHF's move into the field of guideline development should be to solidify the evidence base for an integrated disease management approach. This model of care, also known as comprehensive care, is the foundation upon which our care delivery system is based. Unless this foundation is strong and recognized as being evidence-based, patients and healthcare professionals will continue to have difficulties navigating through what is becoming an increasingly dynamic and challenging healthcare environment, particularly for those of us who live with rare, chronic, high-cost diseases. Recognizing the importance of the national movement to patient-centered care, NHF's foremost goal was to develop a guideline that would speak to patients on outcomes they deemed important and at the same time identify best practices for providers to deliver the care. Next slide, please. I'm pleased to report that the resulting guideline received the endorsement of the American Society of Hematology, the World Federation of Hemophilia, and the International Society on Thrombosis and Hemostasis. I'm not aware of any other guideline in our field that has previously received such broad endorsement. As I already mentioned, our goal was to develop a guideline that would meet the rigorous criteria set out for inclusion in the U.S. Department of Health and Human Services, Agency for Healthcare Research and Quality, or the National Guidelines Clearinghouse. I'm equally pleased to report that our guideline has now been accepted and is available in the Clearinghouse. Next slide, please. Our three learning objectives for today are simple. In addition to sharing with you our findings on the impact of the integrated care model on patients and how healthcare professionals and researchers may use the guideline to improve care, we'll also share insights on how health systems, state and federal policymakers, payers, and insurers may use the guidelines to improve the quality of care that they provide. Now my pleasure to turn the program over to Dr. Minika Pai from McMaster University, the lead author on our guideline. Minika?
Thank you so much, Mark. It's really exciting to connect with so many people today, and it's really been an honor as a representative for McMaster University to work with our colleagues in the National Hemophilia Foundation. So today I'm going to be discussing the development and the recommendations of the NHF McMaster Guideline on care models for hemophilia. And my goal is to spark some ideas on how the strategies that we used could be applied to guideline development in other rare diseases. So this is the official definition of clinical practice guidelines put forward by the World Health Organization. But we are all familiar with what guidelines are. We use them every single day in our clinical practice to give our patients the best evidence-based and standardized care. Countless organizations have published guidelines, but the guidelines that we're going to be discussing today, as Mark mentioned, are the first to be sponsored and developed by a patient organization. A unique feature of this guideline is that it's not intended to provide guidance on what kind of care persons with hemophilia need. Instead, we sought to make recommendations on how that care should be delivered. A number of organizations, including the World Federation of Hemophilia and the European Hemophilia Association, have advocated for integrated care. But this model's effect on health outcomes and the ideal composition of the care team had not been examined. So our mandate was to really determine the optimal model of care for persons living with hemophilia. And our guideline really considered three main models of care. The first model was the integrated care setting. Now, in the U.S., these include the federally funded hemophilia treatment centers as well as the comprehensive care centers. The second model we looked at were specialists in a non-specialized setting. So for example, some hematologists work solo in their own clinics and they do see individuals with bleeding disorders. The third model would be non-specialists in a non-specialized setting. For example, a family physician or an emergency room physician who sees persons with hemophilia on an as-needed basis. By comparing these three models, we hope to identify best practices in hemophilia care delivery. We also focused on the integrated care team itself, discussing the range of care providers and services that are most important to include within it. Now, right from the start, it was very important for us to develop the guidelines using transparent, internationally accepted processes. And as Mark mentioned, it was important to us that the guideline adhered to very high standards, standards put out by the Institute of Medicine as well as the National Guideline Clearinghouse. So it was created transparently with really diligent management of things like conflict of interest. We based it on a strong foundation of evidence and clearly articulated recommendations. We also used the grade system throughout this process. Many of you are already familiar with grade, but I'm just going to do a quick review. Grade is a system that helps us create guideline recommendations with both the direction and strength. So I'd like you to consider this example. When the panel makes a recommendation to use a certain model of care, it's based on the trade-offs between the benefits on the one hand and the risks, burdens, and costs on the other hand. Now, if the benefits outweigh the risks, burdens, and costs, then the panel will recommend that that model of care should be used. So the direction of the recommendation is going to tell us whether we're for or against an intervention. Meanwhile, the strength of a recommendation is the extent to which we're confident that its desirable effects outweigh its undesirable effects. So the recommendation strength is actually based on the quality of the supporting evidence. Unfortunately, it can be very tough to apply grade to a rare disease. We may have a hard time determining the direction of the recommendation because we may not have very much published evidence on the desirable and undesirable effects. And we may not be able to make strong recommendations because the quality of the published evidence may not be very good. For example, there may not be meta-analyses or randomized controlled trials, just a lot of observational studies and case reports, and these are more susceptible to bias and to imprecise results. So guideline development for rare diseases is really tremendously challenging. There's a paucity of data. The disease may not be a priority. It can be hard to design and execute really high-quality studies that generate really high-quality evidence. But rare diseases, like hemophilia, are just as much in need of clinical practice guidelines as common diseases. So in the interest of the patients who live with hemophilia, and also the people who care for them, the NHF and McMaster teams were committed to moving forward with this project. Now, every guideline starts with a set of questions. So for this guideline, we drafted 2 questions. First, should integrated care versus non-integrated care be used for persons with hemophilia? And second, for individuals with hemophilia, who should be on the care team? Should we include a hematologist, a specialized hemophilia nurse, a physical therapist, a social worker, and round-the-clock access to a specialized coagulation laboratory versus an integrated care team with a lesser complement? Now, we actually designed these questions by basically drafting them, sending out electronic surveys to stakeholders to vet our shortlist, and then sending a final list to the panel to review and refine. Outcomes of interest were chosen in a similar fashion. I'm not going to go through all the outcomes, but the take-home here is that the panel felt it was important to understand how models of care impacted outcomes that actually mattered to patients. And that was really the rule that was used as the panel refined and vetted the short list that we provided. So with all this in mind, let's discuss how we actually answered our guideline questions. Now, our work started with a search for published evidence that could yield some answers. So to inform the direction of the recommendation, we conducted systematic reviews. We were looking for data on the outcomes that I just mentioned. We're also looking for information on cost effectiveness, health equity, acceptability, and implementability. To give strength to our recommendation, we also wanted to find high-quality, unbiased data in the form of meta-analyses, systematic reviews, and randomized controlled trials. So that was our ideal. That was on our wish list, but we also accepted observational studies and non-randomized trials. Now, unfortunately, we didn't have much luck. So if you look at this slide, this is just for question 1. We ended up identifying 6,795 papers, and we screened each and every one of them, finally identified 50 original studies that provided information that could inform question 1. Unfortunately, we found no systematic reviews. We found no randomized trials. We found many narrative papers that we had to exclude because they had no quantitative data. And we ultimately ended up with 26 studies, non-randomized studies. And really, we had so little published evidence, and we needed to get very creative to fill in the gaps and to bring some high-quality information back to our panel. Now, there are a number of strategies that we use to fill in the gaps, so I'm going to go through these strategies and tell you how we applied it to our rare disease guideline. Our first strategy to fill in the gaps in the evidence was to repeat our systematic reviews. But we wanted to see how care models worked in more common diseases with more published evidence. So we actually did systematic reviews of congestive heart failure, chronic obstructive pulmonary disease, asthma, and diabetes. And you're probably wondering, why did we choose these diseases? Well, like hemophilia, these diseases are chronic. They're very high resource users. For asthma and diabetes, they affect individuals over the lifespan. And importantly, they deliver care via well-established, multidisciplinary, integrated models. So our research team pulled information on the key outcomes from these 4 diseases, then meta-analyzed and presented the info to the panel. The panel had to decide how indirect the evidence was. That is, was the situations that we are describing, were they similar enough to the situation of people with hemophilia? Could they extrapolate the data we provided and use it to inform recommendations for a hemophilia guideline? We also conducted an iterative qualitative study to generate evidence. Now, as I mentioned earlier, the grade process asks panels to look at quite a bit of information to make good recommendations. We asked panels to consider what outcomes are valued by stakeholders. We asked them to consider the impact of the options on health and equities, and also what treatment options might be acceptable and feasible to stakeholders. Unfortunately, we again found no published evidence to answer these questions for hemophilia, so we had to do the study ourselves. We used stratified purposive sampling, and we recruited through social media. Ultimately, we were able to conduct 29 semi-structured telephone interviews with key stakeholders. We spoke to policymakers, healthcare professionals, patients, and parents, and we used thematic content analysis to learn about care models in centers across the United States. This study, which was published, was fascinating. It taught us how access to care is impacted by age, by ethnicity, geography, and financial concerns. The affected individuals, persons with hemophilia, told us their concerns about the availability of medical experts. They told us what they really thought about comprehensive care and what members of the care team they really valued. Healthcare providers told us their thoughts about funding for the care models, and they mentioned some of the professional factors that make things work and sometimes make things tough. The final way we filled in the gaps in the data was through something called the structured expert observation. Now, I'd like you to consider this. Even though there may be very little published evidence in rare diseases, there's often quite a bit of experiential knowledge out there, usually from healthcare providers who cumulatively have years and years of real-world experience treating patients. So these people, in fact, people like you who are on the call right now, are inarguably the real experts. Now, individually, experts may not have enough knowledge to publish a peer-reviewed study. However, when taken together, the expert experience is invaluable. So we use surveys to systematically capture clinical observations from the Guideline panel as well as other individuals who had been identified as experts in the field. Respondents were not asked for their opinions. Instead, they were asked for more objective information that was supported by their own unpublished data or experience. And we ended up collating this information and then presenting it to the Guideline panel. So after all of the data was collected and synthesized, the panel ended up making its final recommendations. So this is the first recommendation that came out of the Guideline. It stated that for persons with hemophilia, the integrated care model should be used over non-integrated care models. Now, this is a conditional recommendation based on moderate certainty in the evidence. What this means is that on the panel, there was some debate about the magnitude of the benefits of integrated care. There was also an acknowledgement that the evidence was of variable quality, but the panel still felt that there is a clear balance in favor of the integrated care option, given the complete absence of apparent health harms. And that's why this recommendation looks like it does. Now, the panel strongly recommended integrated care for inhibitor patients and those at high risk for inhibitor development. Now, why did they make a strong recommendation in this case? Well, it's because the evidence suggested a larger absolute benefit of integrated care for individuals with inhibitors, as they appear to be at highest risk of harms and thus have the most potential for benefit. Now, the final recommendation from the Guideline panel had to do with the composition of the integrated care team. It stated that for persons with hemophilia, the team should include a hematologist, a specialized hemophilia nurse, a physical therapist, a social worker, and round-the-clock access to a specialized coagulation laboratory over a team that has a lesser complement of individuals. Now, again, the overall certainty of the evidence for this question was very low. There were no available studies, either randomized or non-randomized, comparing the impact of the presence or absence of specific healthcare professionals as part of the team. However, we still were able to make a conditional recommendation here, and that's because the panel acknowledged that the integrated care model, as commonly implemented in the United States, so as commonly implemented according to this slide, does produce a benefit. And it is also obviously feasible to implement because it's working in centers across the country. And also that there really appears to be a clear balance of benefit in favor of the full complement of this integrated care team. So now we've reviewed the methodology and recommendations of the Guideline, so I'm going to turn the presentation over to Dr. Stephen Pipe.
Thank you, Dr. Pai, and it's my pleasure to be part of this panel today and to discuss with you how we would use this guideline as a resource to improve quality across the U.S. health landscape. So as we go to the next slide, there's really two areas of engagement that we should be considering with regards to focusing on improvement. One is on implementation of the guideline, and then secondly is how this guideline can be utilized for further research. We'll also talk about a little bit later what the implications of this is at a macro level and also at a micro level, and I'll explain that a little bit further. So let's talk about implementation first. So as we go to the next slide. The goal should be enhancing implementation of this integrated care model. If we are going to stand behind the findings of this panel and the evidence and the strength of that evidence, this should lead us to at least 4 points that are highlighted in the bullets here. One is to identify and address barriers to accessing this care. Those barriers could be health system, they could be payer, they could be geography, they could be socioeconomic. But if we're going to use this guideline to enhance implementation, identifying and addressing those barriers would seem to be a strong priority. The second thing is to standardize components of the integrated care model. You saw from the presentation so far that there at least is some uncertainty about exactly what the key components should be. There is some common ones that are utilized around the country, but we definitely need to be looking at how the integrated care model is being implemented across the country, and which components need to be core and which ones can be ad hoc. And we also need to consider that as the paradigm shifts occur in the treatment for hemophilia and other bleeding disorders, how might that impact the standardized components of the integrated care model? There's an opportunity to develop patient-important performance measures. You saw that that was a key part of the development of this guideline. And if we're going to be testing how well we're implementing that model, we should have outcome measures that we can report on to demonstrate that those patient-important performance measures are being met. There's another opportunity, and that is we have to be able to staff these integrated care models for the long term. So how are we training, how are we recruiting and retaining specialized healthcare team members so that the viability of this integrated care model lives on for decades to come? Next slide. So moving from implementation to setting priorities for research going forward. We can use this guideline through the network to identify unique populations that need to be studied deeper. We have a growing geriatric population for the first time, even with severe hemophilia A. There's increasing numbers of female carriers that are being incorporated into and taking advantage of this integrated care model. We know that there are populations who have poor access to care, and they are a challenging group to do research, since most of the research we're conducting is occurring within the integrated care model within the HTCs. So for those persons with hemophilia who access care outside of the HTCs, how are we going to get access to that data and that outcomes data and pool it with the data that we already have within the HTC network? Some interventions that can be studied. Which aspects of the integrated care model are value add, and what's the impact of remote care delivery systems? So I mentioned geography as one potential barrier. There's certainly different models for care around the country where there may be a centralized HTC and then remote outreaches into other challenging parts of our geography. And what's the impact of those systems? Is there opportunity for improvement, or is there even opportunities to expand those models even within more densely populated geographies of the country? And then research on outcomes to study, the cost of the care that we provide. Does this have an impact on factor utilization? And what are some of the impact of unique patient factors on outcomes? And this maybe goes back to some of the issues we talked about already related to different payer systems, geographies, and socioeconomic conditions. Next slide. So I mentioned how this guideline could impact in improving care at the macro level. So what we're meaning here is, what does this guideline mean to payers and insurers, hospitals, healthcare systems, federal and state programs, and policymakers. Well, there's a few things that I think we can take away. I think it confirms that the HTCs are responding to healthcare reform and continuing to provide high-quality care of hemophilia, and also creates a framework to evaluate successes and shortcomings of models of care delivery and their impact on patient-important outcomes. It also underscores the role of HTCs in tracking safety and efficacy of therapies and developing cost-effective treatment paradigms. So this gives us stories to tell at a macro level to payer systems and state programs and policymakers, etc., about the work that is going on within HTCs. And we can be ahead of any changes that might be coming down the healthcare pipeline that threaten this integrated care model and its implementation and the research that's being conducted in this setting. The next slide. So next we can talk about what this means at the micro level. What does this guideline mean to individual healthcare providers and researchers? The first thing I can say is that the network is prepared to support evidence-based performance benchmarks to evaluate the system and individual HTCs. If you're familiar with conducting clinical care through the Hemophilia Treatment Center network, you know that quality improvement is now a major part of what we're doing across the network. This is in partnership with the Maternal Child Health Bureau and through the NHPCCC through the HTC network. And there have been organized teams that have gone out and are training HTCs on how to implement quality improvement at their centers. And it's a grant requirement of our reporting to the federal government on the work that goes on at the HTCs. But ultimately, this could also lead to a self-audit program or an accreditation system for the HTCs. I don't want you to take away from this any sort of punitive aspect to this, but really more a recognition system for the quality of the work that we conduct through the HTCs, and give a benchmark that individual centers can rise up to or demonstrate that they're meeting with regards to evidence-based performance benchmarks. In addition, this is going to lead to support for new studies to specify a coordinated set of diagnostic, therapeutic, and auxiliary and supplemental services that are most important for hemophilia patients across the U.S. And I think about the implications at my own center is that as we continue to do work and we focus on these evidence-based performance benchmarks, we can highlight where we may feel that we're limited, where we're missing key aspects of the integrated care model, and we can advocate within our individual centers for specific needs. It could be manpower needs, it could be infrastructure, data collection, etc. And so I think this is adding strength for advocacy at the HTC level. Next slide. I think the last thing we can talk about is, again, within the micro level, is what does this guideline mean to patients? And I think that one of the top ideas that's come from this is it does establish the idea of a standard of care. And I think as our population still has opportunity to move around the country, or they have contacts with individuals from other centers in other states, etc. I think this has percolated up as an important issue is, do we have a standard of care across the HTC networks? Do we have pockets of our geography where we're challenged to meet that standard of care? And if there are centers that are meeting that standard of care or exceeding it, what is it that is allowing them to achieve that? It also acknowledges that every patient has unique needs, and I think, again, that comes back to this patient-centric aspect of this guideline. And our integrated care model needs to be able to meet the needs of each individual patient that is seeking care through our centers. It empowers patients to communicate with their providers, to advocate for a core complement of services, as well as advocate for care in an integrated setting. And so again, I think both at the macro level and the micro level, including the HTCs and the individual patients, the impact from this guideline is going to be far-reaching and something that we're going to be working through together for many years to come. Next slide. Here I want to direct you to where this guideline was published in the journal Hemophilia. This is a detailed guideline, and it's also it includes an introduction to the care models in hemophilia. There's a methods paper as well as 2 systematic reviews and a qualitative study, all combined together in this supplement, and the reference there as well as the hyperlink is provided for you. In addition, the online data supplements through the journal site give additional evidence profiles, so essentially the data that inform the guideline, as well as evidence to the recommendation table, so outlines how evidence was used to inform the guideline's final recommendations. And you can get additional information in this regard from the NHF website at www.hemophilia.org. So with that, I'd like to turn it back to Mike.
From this kind of integrated care. Dr. Pai?
Could you repeat that question, Mike? I think you just went in and out there.
Oh, sorry. So I was just saying that you provided a lot of information about all the work that was done on this guideline to inform these care guidelines, and I was wondering how some of that work might be useful to inform care guidelines for other rare disorders that people may have in the States.
Sure. So I think this challenge that we faced in building this guideline, it's a common challenge. Rare diseases, each individual one, of course, is rare, but when taken in total, rare diseases pose a real challenge to patients, providers, payers, and policymakers. And we feel that some of these novel strategies could be widely applied, and in fact, we are actively applying them in other rare diseases, whether that's using qualitative research to generate more data on things like values and preferences and equity. There's actually a group called CIRQUAL, which stands for Confidence in the Evidence and Reviews of Qualitative Research. It's a subgroup of GRADE that's actively working in that area. We think that the use of structured observations are really exciting. They replace that idea that experts just sit around a table and swap ideas. This is a much more formal and transparent way to deal with things, and certainly the approach of parallel systematic reviews is also applicable. So we did successfully apply these strategies with this guideline with hemophilia. There's a European consortium called Rare Best Practices that is actively applying this to other areas, and they have recently been applied to a guideline developed on catastrophic antiphospholipid syndrome, which I believe is in the process of being prepared. So this is a super exciting space. Lots of people are working in this field, and I think that this provides incredible promise for guideline development in many, many different rare diseases.
Very good, thank you. So I have another question. This one perhaps Dr. Pipe may want to address. So the question is, can can we implement these guidelines, or can people implement these guidelines in developing countries? And how might that occur? And your thoughts about how that might benefit?
So I think this is the model that groups like the World Federation of Hemophilia have encouraged to advance care across the world. In fact, just from my familiarity with some of the twinning activities that the World Federation has used, I know that this level of integrated care is often right at the heart of initially what contributes to significant improvement in care in a country, even without improving access to replacement therapy. The integrated care model can lead to improved diagnostics, to data collection, to helping identify patients and get them directed to a specialist who can care for them. So I think almost certainly this guideline should be looked to as a strong call for action within countries where there may presently not exist this kind of integrated care model, and it probably is the least cost involved to significantly advance care in a developing world.
So I was wondering if Mark, as a former president of the World Federation of Hemophilia, you might have some thoughts in this area as well.
Thanks, Mike. I think Steve summarized it very well. The reality is, when the World Federation does begin to work in many developing countries, the simple organization of care, building it around the patient with the core components, is the important first step. It often is the easiest thing to achieve, particularly in national health systems where they have the ability to actually structure care and have a coordination of services. The other point that I would just mention is, I'm counting off the top of my head, but I think at least 4 of the panel members for the guideline were actually international members. So we sought, both in our evidence review as well as in the membership of the panel, to bring an international perspective. So although this was a guideline sponsored by the U.S. National Hemophilia Foundation, I believe it is our belief that it has global application, and I think that's reflected with the endorsements of both the WFH and the ISTH.
Okay, thank you. So I have a question here. It's how, or if or how, the guidelines may be utilized for the HTC 340B programs as a component of the comprehensive integrated care model. I'm not exactly sure, perhaps someone may understand exactly what that question is. The 340B pricing program through HRSA and all allows some of the costs to be able to benefit the patient. So I think it's perhaps a question of how to use that resource, perhaps to implement this guideline. Anybody have?
I'm not sure exactly what the direction is for that question, except that part of the integrated care model is taking advantage of this this opportunity to leverage 340B acquisition pricing to contain costs for hemophilia, and then also to help provide infrastructure support for this integrated care model. So basically, I guess I would look at it as it's an opportunity for the federal government to continue to support HTCs through this mechanism. And we know it's been an important part of allowing the staffing of these integrated care models across the U.S. I think it's almost certainly the sheer number of HTCs we have in the country would be dramatically reduced outside of the 340B program. And so I think having the strength of this guideline, having it endorsed by the endorsements that were mentioned at the beginning, as well as present in the publishing clearinghouse, gives strong advocacy at the government levels when they're having budget decisions making or when working with policymakers, etc. We can really strengthen the value of the 340B program and how it helps support the implementation and the access to the results from this integrated care model. So I see them as intertwined, and I see this as a really strong advocacy tool in that regard.
Okay. So I have another question here. So we've been talking about an integrated care model that my understanding has been implemented in the federally funded hemophilia treatment centers, but it's not really certain about outside of that network. And I was wondering how this model, how it could be, or if it should be, adopted in other settings, perhaps outside of the federally funded treatment centers. Maybe someone could comment about that.
So, Mike, this is Mark. I could say just a couple things, and others may be thinking while I'm talking. I think first, I think there is a very powerful message in this guideline as it is directed to patients. So to the extent that patients are making a choice and they may not appreciate the value or the difference a treatment center can make in their outcomes, it may be instructive to patients and help inform them when they decide where to get their care. I think the other piece which was discussed within the guideline panel was the notion that just sheer geography does not allow a treatment center to be next door to every patient, and therefore distances are something that have to be overcome. And as Steve was laying out some of the longer term research objectives, figuring out how to use the integrated care model remotely in distant learning or management may be an important future area of research to demonstrate that those kinds of other outreach tools to bring the comprehensive or integrated care model closer to patients may supplement what they get locally if they're not seen regularly in a full center.
Okay. Do any of the other panelists have any comments on that?
Well, I may have a question for Dr. Pai is how much data the panel even had to evaluate on care outside of the HTC, or outside of the integrated care model, and before we can, I guess, really assess what the challenges are in that environment. Is there even enough data, or does this have to be a priority for research going forward?
Yeah, I think it's a great question, and it's a huge priority for research. So, I tried to lay out what a challenge it was to really find any high-quality published data, to be honest. And you're right, Steve. There was quite a limited amount of information on the experience of individuals who were outside of the HTCs. So I think that there's a couple of issues that come out of that. I mean, first of all, the panel did make a recommendation for integrated care, but that was partly because there appeared to be a balance in favor. So there appeared to be favorable effect on patient-important outcomes, and also a complete absence of health harms. That, as I laid out, there was really a paucity of good comparative studies. So I think comparative studies would be a huge research priority. And also I think that qualitative research may play a large role here, really understanding the experiences, the barriers that Mark alluded to, whether they're geographic or socioeconomic, and also understanding their experience both within and outside of the HTC, because as we learned in some of our qualitative interviews, some patients and providers have experienced both systems. So looking for comparative data using that type of research, I think, would be very exciting and very, very important and potentially very impactful on patient care.
I think one of the issues for me is I don't know that we have enough data to be able to say things such as, well, we need to help expand the integrated care model outside of the federally funded HTCs, or we need to, raise the bar of care for patients who are outside of this system. I think there's plenty of work to be done at access barriers that have nothing to do with where patients live in the country. There may be specific examples where that's an issue, but we have patients who are literally, next door to us, providing and fully staffed with these integrated care models, and patients are not making it to our centers. And I think that's an area where there can be immediate work done related to this guideline, and try to knock down those barriers first. I think big pushes outside of the HTC network to raise the standard of care, may end up being counterproductive. I mentioned some of the issues around training and recruiting and staffing these centers for the long term and ensuring we've got viability. It's just not clear that further expansion of this integrated care model at other sites is really going to be the direction that we need to go. And so I think there's plenty of work to be done on just making sure patients get access to the sites that are already providing high levels of care in this area.
Yep. So Mike, just to build on what Steve said, I think that was recognized by the panel, is that we're living in a very dynamic healthcare environment, and structures of the way people access and receive care today may be very different in parts of the country, but they may also be different in the future. So we were not trying to create a box with absolute walls that said it all had to be available in a certain particular way. But what we did say was that the services need to be available in an integrated fashion, and they could be available within one setting, or they could be available through a variety of mechanisms within an academic institution, or working locally in partnership with other specialists. It's the nature of the 4 or 5 essential components that is important to reaching the conclusion, and that could well evolve over time.
So this has been really really informative. This next question is really sort of in the same area, but coming from a little different direction here. The question is, what is being done to align third-party reimbursement to cover the costs of the integrated care team, both from public and private insurers? So this is coming from the standpoint of how do we keep these integrated teams available to take care of the patients.
I could make one comment, and again, Steve may have some others. In another project that the National Hemophilia Foundation is working on, they have a program called the Comprehensive Care Sustainability Project. There have been some material published, and I believe it's available through the NHF website as well, where NHF has actually used the results of this guideline and has spent time talking with payers about the kind of data they would like to see, and about the inclusion of the HTCs in the broader care networks. So the thought is that this will be powerful in terms of persuading payers to include HTCs in the network, but also in the HTCs and the payers working together so that they can provide the metrics and the long-term data. So this goes back to part of Steve's earlier comment about the need for sort of longitudinal outcomes monitoring. And if we know these are the components that make sense, then we maybe need to build those into our data collection systems, either through Athens or elsewhere, and make those available in a uniform format that the payers then would recognize. So it is part of a systems approach, but we do think that this is part of the access equation.
Yeah, I was going to mention the sustainability project as well, and being involved in some different components of that and interactions with payers. And when we say payers, we're talking about private payers, as well as state Medicaid programs, etc. And I think what we're seeing through those interactions is a recognition of the importance of the integrated care model, the fact that it's being executed well through the HTC network, the health benefits, and I think it's a really high value to have these interactions. It really improves the awareness of how hemophilia is cared for across the country. And I think universally, these payer systems are recognizing the add-on value of this integrated care model. And so the guideline just adds additional strength to those interactions. And so as they're starting to come up with their own components of how they're, quote, managing hemophilia through those payer systems, I think there's great opportunities to leverage the evidences that are part of this guideline and really work together to a common good here for our patients.
Okay, so I have one more question I think we have time for. And Mark, I think you touched on this earlier. But the question is, what do you see as the role of patient self-advocacy?
So I think both Steve and I touched on it. Patients, and I am a patient, we want to know that at the time that we're investing in receiving our care and where we're going to receive our care is going to produce the best outcomes. And so the kind of data that could be collected in the evidence here, I think, is going to allow patients to enhance their conversation with their healthcare professionals. If they see a model of care that they don't feel like they're receiving, or if they do not feel like it is all available, then I think it gives the strength of the patients to have that conversation. We're moving much more towards personalized medicine and shared decision making, and to the extent that patients are armed with the evidence and understanding of what does make a difference, they can couple that with their own personal priorities and the outcomes that are important to them to actually personalize the care so that they can optimize the system or work with their HTC and in the advocacy programs of one of the patient organizations, either locally or nationally, to get the resources to round out the equation. So I think this both works at the personal level, but also it's going to support advocacy initiatives because we know resources are limited as well.
Okay, well, I would like to thank our panelists for a terrific webinar presentation today. And I'd also like to thank each of you for joining us. We'd also like to thank our colleagues at the Hemophilia Federation of America for hosting this webinar. Very shortly, you'll receive an email asking for your feedback on today's webinar, so please respond with your comments. If you have additional questions about today's presentation, please contact Cynthia Sayers at CSAYERS@cdc.gov. This webinar will be archived and the content will soon be available at CDC's Division of Blood Disorders website as shown on the slide. Please join us next month when we hear from Dr. Michael Strife from Johns Hopkins Medicine. Dr. Strife will be speaking about the prevention of venous thromboembolism and share his experience in the Johns Hopkins VTE Collaborative. Thank you for joining us today, and have a great afternoon.